Osteoarthritis. Osteoarthritis is by far the most common form of joint disease throughout the world. It is strongly associated with age and extremely common in older people. Some studies estimate that over 80% of people over 55 years of age have osteoarthritis of at least on one joint. It mainly affects the hips, knees, spine, hands, and feet. The disease process leading to OA result in a final common pathway of joint failure akin to heart or kidney failure. Clinically, osteoarthritis or joint failures is a very heterogeneous condition, but is the end result of biochemical and mechanical insult that exceeds the joint's ability to repair itself. Classification and subtyping are difficult. Joints occur where two or more discrete bones meet each other in the body. These joints can be fixed or can allow movement between the bones. There are three main types: fibrous joints, cartilaginous joints, and synovial joints. Fibrous joints are bone of the cartilage by fibrous tissue and allow the very little movement, such as the sutures of skull. Primary cartilaginous joints are between bone and hyaline cartilage. In secondary cartilaginous joints, the two bones ends are covered in a thin layer or hyaline cartilage, and these two ends are joined by intersposed fibrous cartilage. Synovial joints have involved in order to allow movement between bones. The adjoining bone ends are covered by extremely smooth hyaline cartilage. This junction is enclosed within a joint capsule containing synovial fluid, which bathes and lubricates the hyaline cartilage. The capsule is lined by a synovial membrane that contains cells called synoviocytes. All the structures that compose synovial joints can fail and lead to the final common outcome of osteoarthritis. Once one structure begins to fail, the surrounding structures are affected adversely and then also fail. Normally, the insult, whether biological or mechanical, affects a number of structures simultaneously, and the remaining structures secondarily. Subchondral bone supports of the overlying hyaline cartilage. It is susceptible to fracture when subjected to great compressive force or to a vascular necrosis within when subjects to shear forces. Collapse of the subchondral bone leads to splitting of the overlying hyaline cartilage. Synovium can become inflamed due to chemical irritations such as crystals or infection. Additionally, the synovium is prone to inflammation resulting from systematic immune-related problems as in rheumatoid arthritis. The cytokines in the synovial fluid affects the catabolic and anabolic activities to the chondrocytes. And osteocytes in the nerve, cartilage, and bone, as well as the capsule, leading to alteration in the normal integrity of these tissues, rendering them more susceptible to mechanical insults. Failure of hyaline cartilage results in the subchondral bone being subjected to both increased load and direct pressure from synovial fluid. The final common pathway of all of this mechanism is damage to hyaline cartilage, increased load on the underlying bone. This formation due to penetration of the subchondral bone by synovial fluid under pressure and new bone formation on the joint margins. The development of osteoarthritis therefore can occur as a result of any form of joint disease. Etiology and risk factors. Genetic predispositions from twin studies and other data has been estimated that about 40% of the predisposition to osteoarthritis may be genetic. However, there is no osteoarthritic gains. Rather, several different sites within the genome each confer a small increased risk. Many of the sites associated with this increased risk relate to genesis important to skeletal development, aiding to other evidence that suggests that bone size and shape are important determinants of the likelihood of getting osteoarthritis. Age. Osteoarthritis is strongly associated with the increasing age, but this is not because age-related changes in joints are similar to those of osteoarthritis. There are major differences of the pathology of aging joints from those of osteoarthritis, and it has been suggested that they would need to live for our 200 years before the age-related changes in the joints alone would cause osteoarthritis. The association with age may have more to do with joint stability and muscles than joints. As we age, our cartilage gets thinner and our muscles get weaker, and the stability of major joints such as the knee may be affected in subtle but important ways of this change. Gender. There are differences in prevalence of osteoarthritis between men and women. The reasons for this are not clear. Changes related to the female menopause appear to be particularly important as knee osteoarthritis prevalence in women with this shapely after the menopause and inflammatory osteoarthritis of the hands often starts during the menopause. Diet and obesity. Obesity is a strong risk factor, particularly for knee osteoarthritis. It is also a risk factor for increased incidence of hand osteoarthritis, suggesting that it may have some systematic influence, perhaps throughout change in obesity-related biochemical factors such as leptin levels. In addition, there have been a number of studies to suggest that some vitamin definitions may be important in the development of osteoarthritis, including vitamins C, D, and K. Abnormal joint shape and size. Joint shape is an important risk factor, particularly for hip osteoarthritis. Hip dysplasia predisposes to hip osteoarthritis in later life, and more subtle abnormalities of the size or shape of the head or of the femur or acetabulum may be responsible for much of the common or garden hip osteoarthritis seen. The differences in shape of hips in Chinese from that in Caucasians may explain the low prevalence of hip osteoarthritis in Chinese people. It is possible that joint size and shape are also important on knee osteoarthritis. Previous injury. Injuries that affect the shape or stability of a joint predispose to osteoarthritis. This is most apparent in joints which have a low prevalence or common or garden osteoarthritis, such as the wrist or ankle. Osteoarthritis at these sites is usually due to a previous significant injury. At the knee joint, meniscal and ligament injuries, particularly anterior cruciate ligament rupture, are important predisposing factors of osteoarthritis. Neuromuscular problems. Several neurological problems of specific types can lead to the important variant of osteoarthritis called Charcot's joints. Lesser forms of neurological change, including weak muscles and loss of proprioceptions, may be important in common or garden osteoarthritis. In addition, joint laxity seems to predispose to osteoarthritis. Conversely, spasticity results in very tight joints accompanied by abnormal joint loading, leading to joint damage and secondary osteoarthritis. Osteoarthritis of the hip is particularly common in patients suffering from spastic cerebral palsy. Joint loading, occupation, and obesity. The extent to which normal of excessive joints use, including exercise, risk factors of osteoarthritis or alternatively protective to the condition is a contentious issue, and we don't know yet understand exactly what aspects of joint loading matter most to joint health. However, certain specific occupations involving repetitive overrise of joints can predispose to osteoarthritis, resulting in special forms of the condition, such as a Pica-Tamper's thumb, osteoarthritis at the base of the thumb in people who spend their working days shifting printing blocks around with their thumbs. The fact that obesity is particularly important for knee osteoarthritis indicates that a part of the risk is likely to be due to loading factors as well as any systematic influence. Bone minerals density. Long ago, it was noted that people who came to hip replacement because of fractures caused by osteoporosis were unlikely to have hip osteoarthritis. Subsequent studies have confirmed that both of knee and the hip high bone mineral density is a risk factor of osteoarthritis, and low bone mineral density is protective. It is not understood how these relationships operate, and it is unclear to the extent these are the systematic factors of whether it is about local loading of cartilage and subchondral bone. Pathology and pathogenesis. Great first softening and swelling of the cartilage. Grade 2, fragmentation and fissuring of the cartilage in areolas half inch in diameter. Grade 30, fragmentation and fissuring of the cartilage in an area of more than half inch in diameter. And grade 4, exposure of underlying bone. The one used most commonly of the Kelvin and Lorentz scoring system, which divides osteoarthritic X-ray change into 5 categories. 0, normal, no features of osteoarthrosis. First, Daptfall, minimal osteophyte, Daptfall significates. Second, minor definite osteophyte, no loss of joint space. Three, moderates some domination of joint space, and for several advanced joint space loss, loose and sclerosis of bone. Pathogenesis. The early change in cartilage appear to result from collagenase enzymes disrupting the integrity of the type 2 collagen matrix, which includes the hydrophilic proteoglycans, leading to swelling and softening, subsequently more proteolysis and damage to the proteoglycans, as well as the collagen results of the fissuring and loss of volume. Picture A, the X-ray shows loss to the articular cartilage of the superior pole and the cyst of the underlying bone, the spaceman. Picture B shows that the top of the femoral head was completely denuded of cartilage and the large osteophytes around the primary periphery in the coronal section. The picture C, the subcortical cyst of the globally revealed. And picture D, fine detail X-rays show the extent of the subarticular bones destruction. Symptoms and signs. First symptoms, it's pain. Most people with clinical osteoarthritis report discomfort or pain in or around the joint affected, but their pain experiences vary highly, both over time between individuals and as outlined future below according to the joints affected. It's very common for patients to have trouble describing their pain. They often refer of the seizures as a deep-seated discomfort similar to the curettage emanating from within the joint. Reported experiences vary from a due age after exercise throughout to the more common moderate activity-related pain to excruciating continuous pain and pain or at night. Severe pain that wakes the patients nightly is a particularly debilitating symptom of severe arthritis and leads to sleep deprivation. Many people report that no 2 days are the same, the pain experience being variable and seemingly inexplicable. Other symptoms stiffness or galling of the joint after inactivity is a classical features of osteoarthritis, resulting in people having difficulty getting moving after resting. This is particularly common on the early morning after first awakening. The cause is not known. Less well applicated symptoms of osteoarthritis include fatigue, sleep disturbance caused by pain, and anxiety or depression. Each of these very common and can have a big impact on individuals, and as discussed below, maybe need management separately from any attachment to deal with joint damage or pain. On examination, the joints affected may appear swollen. There may be evidence of wasting and weakness of surrounding muscles. And in advanced osteoarthritis, joint deformity, palpation may reveal bony swelling at the margin of the joint, signs of mild inflammation such as height of the joint line and the fusion. One movement there is usually a reduced range with the pain to the end of the range, and crepitus may be felt as the joints is moved. In advanced disease, instability may be detected. Symptoms and signs at different joint sites. Hips. Pain is usually felt in the groin laterally over the hip and radiates down the anterolateral aspects of the thigh to the knee. Occasionally, the pain can radiate beyond the knee. Referred pain felt only in the knee is not uncommon, and clinical should always consider hip osteoarthritis as a cause of isolated knee pain. Pain is worse on exercise and walking distance is reduced. Pain at rest and night pain can be particularly troublesome. Stiffness is usually experienced first things in the morning and after having sat still for a while, but it quickly resolves on movement to be replaced by pain. Complex movements such as getting in and out of motorcar or putting on socks, which involve deep flexion combined with rotation, after often difficult or impossible to perform. Patients struggle with stairs, and the absence of a banister may only manage stairs on all fours. Examination reveals an antalgic gait characterized by an uneven cadence in which less time is spent in the stance days of the painful limb. There is a globally reduced range of movement with internal rotation often restricted early in the disease progression. Joint move is limited by pain at the extremities of movement. Knee. Knee osteoarthritis occurs most commonly the medial tibiofemoral joint, but can occur in all three compartments, is often tricompartmental. Isolated patellofemoral osteoarthritis is probably due to altered biomechanicals of the extensor mechanism. Pain is felt globally over the knee and the proximal tibia. In isolated patellofemoral osteoarthritis, the pain is felt anteriorly over the knee and is often more worse when ascending or descending stairs as the patella is compressed against the femur. As in the hip, the pain is a deep-seated, acute sensation related to exercise. Rest pain and night pain develop in the later stage of this disease. Patients sometimes report audible crepitus, cracking or grunting sounds coming from in the knee, as well as symptoms of instability. They may notice gradual deformity of the knee, in particular varus deformity, but less commonly valgus deformity. Fixed flexion deformity means that the knee cannot lock in full extension, and those patients cannot stand comfortably for prolonged periods due to muscle fatigue. Loss of flexion beyond 90 degrees makes standing from a sitting position difficult as patients cannot move the center of gravity anterior to the mid-coronal plane. Swelling and stiffness are common features. Examination reveals an enlarged gait, wasting of quadriceps muscle, joints effusions, joints deformity, and crepitus palpable, and sometimes dubial of movement. The joints deformity may passively correctable deformity is towards the compartment most severely affected, usually varus deformity with predomination medial compartment osteoarthritis. There is sometimes tenderness along the joint line and palpable osteophytes that can be tender. You can see osteoarthritis of the knees and the X-ray. Osteoarthritis grade 3 or 4 classification Kelvin Roberts. Hands. The joint sites commonly affected in the hand are the distal interphalangeal joints and the thumb base, less commonly proximal interphalangeal joints and the metacarpal phalangeal joints were also involved. Osteoarthritis of the hand is strongly associated with osteoarthritis at other joint sites, especially the knee, and with genetic predisposition of osteoarthritis, suggesting that is the future of generalist common or garden osteoarthritis, but it has several unique pathological and clinical features not often seen on other sites. It's far more commonly in women and the time of the menopause with painful inflammation in the distal interphalangeal joints all the time. The inflammation settles and the joint is left with the typical pathological features of osteoarthritis. Erosions can occur and cysts containing hyaluron that protrude at the margins of the joints are not uncommon. Distal interphalangeal joints osteoarthritis is not generally a major problem in terms of function, but thumb-based osteoarthritis can be as it leads to instability and difficulty with the punch grades. You can see in these pictures interphalangeal joints, distal interphalangeal joints, and X-ray and symptomatic therapy. Step 1. Take a holistic approach and encourage self-management. This means cessation of the impact of the osteoarthritis on the individual's quality of life function, mood relationships and activities, thinking about the context and any comorbidities, and thinking about the potential risks and the benefits of any intervention. Self-management strategies include considering alterations of diet, alternation of activities, change footwear, taking a more positive approach to the condition and exercise more. Step 2, introduced the co-treatments appropriate for most people with osteoarthritis. This includes the provision of information about the condition and its management, helping people to increase the exercise level and to do specific exercise to strengthen muscles around the affected joints. Footwear advice and help with the weight loss for those who are abused. Step 3. Introduce specific non-surgical interventions. There are many pharmacological or non-pharmacological. The non-pharmacological interventions of proven value often include supervised courses of physical therapy or the use of aids and devices to reduce instability to the help within functional problems, walking aids such as sticks or crutches. Some electrotherapy techniques such as TENS mechanisms for pain control and some manipulation, particularly in the case of the hip osteoarthritis with a reduced range of motion of the hip. Pharmacological options include the use of regular or on-demand paracetamol and topical NSAIDs, which are considered to be the first choice of pain. More recent evidence has suggested that paracetamol is not better than placebo, but both have been demonstrated to reduce pain if there are insufficient NSAIDs. Cyclooxygenase second inhibitors and opioid analgesics can be considered. Intra-articular local anesthetic and corticosteroid injections can be considered as an adjunct to other treatments, but hyaluronan injections are not recommended because of lack of evidence. The very widely used nutraceuticals such as glucosamine and chondroitin are not recommended because of lack of robust evidence to support their use. Step 4. Consider surgical options. There are many different surgical options available as discussed in more details on other chapters on the book. Surgery is broadly divided into joint rearrangement, joint fusions, joint excisions, and joint replacements, which may be total or partial. Joint debridement, such as arthroscopic knee debridement, has largely been discredited by randomized controlled trials of sham surgery versus debridement, which showed to treatment benefit. Surgery is usually confined to end-stage disease once pains have been refractory to other treatment options. Hip and knee replacements are particularly successful treatments for advanced osteoarthritis, often resulting in complete resolution of pain and dramatic improvement in function and the quality of life. However, a small but important minority of patients do not benefit from joint replacement and have persistent severe pain in the long term post-surgery despite no evidence of technical issue with the surgical performed.